Hi, my name is Patrick and I'm a Pulmonary and Critical Care Fellow. This video is on breathing reserve. So our breathing reserve, or ventilatory reserve, is the expression of our maximal minute ventilation as a fraction of our ventilatory capacity, and we typically use our maximal voluntary ventilation as a measure of our ventilatory capacity. Here we have maximum voluntary ventilation, or MVV, which we can calculate by multiplying a patient's own FEV1 by 40 or by 35. Obviously, using a lower number will prevent overestimating a patient's capacity, and we use a patient's own FEV1 rather than from large published tables because using their own FEV1 provides us with a more individualized ceiling for what their specific respiratory system can achieve. Now we're superimposing maximal minute ventilation on top of maximum voluntary ventilation, or MVV, to represent the breathing reserve. So the breathing reserve is the fraction that is left between the maximal minute ventilation and the MVV. Depending on what part of the world you're in, it can be expressed different ways. In the UK, it's expressed as maximal minute ventilation divided by MVV, and normal is less than 80%. In the US, we're largely influenced by Carlman and Wasserman, and we use a slightly different equation, and we define normal as greater than 20%. We, in our own lab, typically say normal is about 30%. This is the 9-panel plot, and when you're looking for breathing reserve, you're looking at panels 5 and panels 9. As a quick reminder of the 4 phases during a CPET test and the 3 vertical lines separating those different phases, keep these in mind as you see them on the next few panels. Here we're looking at panel number 5, looking at minute ventilation relative to time. As you can see, it's a very linear increase to maximal exertion followed by the recovery phase. Keep in mind it is our cardiac output that typically limits our ability to exercise. So a small or absent breathing reserve strongly suggests constraint by breathing mechanics, either because of a reduced breathing capacity or because of exaggerated breathing requirements because of inefficient pulmonary gas exchange. It's important to remember that well-conditioned athletes may also reach the limits of their breathing capacity even with normal lung function. So whereas a small or absent breathing reserve is evidence of exercise limitation because of lung mechanics, the presence of a breathing reserve doesn't necessarily exclude pulmonary factors causing dyspnea. If we contrast that smooth linear increase in minute ventilation over time with this graph, we can see that this is quite erratic, and this is an example of dysfunctional breathing. Now we're looking at panel number 9, and this panel is looking at minute ventilation versus tidal volume. In a normal healthy patient, the resting tidal volume is approximately 10 mils per kilo, so an 80 kilo person has a tidal volume of 800 mils. And this panel, comparing tidal volume to minute ventilation, is useful for determining abnormalities in the rise of either tidal volume or respiratory rate. Because if ventilation increases without much rise in tidal volume, then it must be because they're increasing the frequency of their breathing. So patients with lung disease tend to have a flatter VT to VE plot, and they reach this plateau much earlier because they're relying on increasing their rate more than their tidal volume, especially those with restrictive lung disease, but it can also be seen in obstructive lung disease because of dynamic hyperinflation. So here you can see a slightly flattened VT-VE plot that you would see in disease, and here you can see the breathing reserve, which is the distance between the maximal minute ventilation achieved, or the peak minute ventilation, and the MVV.